I need to share something with you that could completely change how you look at your cholesterol numbers. This is information that may help you avoid taking medications you don't truly need, or even worse, medications that could be doing more harm than good over time. I'm Dr. Maria Lee, and after more than 23 years practicing cardiology, I've watched the medical system continue to rely on cholesterol guidelines that simply were never designed for people over the age of 65. The reality is that much of what seniors are told about cholesterol is based on research done in younger adults. And that creates a serious problem. When your doctor sees a total cholesterol level of 240, the reaction is often automatic. A prescription is written. A statin is started. The goal becomes pushing that number below 200 as quickly as possible. That approach follows long-standing protocols and traditional training. What often goes unmentioned is that the relationship between cholesterol and heart disease changes significantly after the age of 65. The numbers that may have been protective in midlife do not always function the same way later on. What helps at 45 is not necessarily what helps at 70. This is not widely discussed, and there are strong financial reasons for that. Cholesterol-lowering medications generate billions of dollars each year, and there is little incentive to revisit assumptions that benefit that system. I'm going to walk you through research that many physicians are unfamiliar with or choose not to emphasize. I'll also share real patient experiences where aggressive cholesterol lowering led to a serious decline in quality of life, even though their cholesterol patterns were not dangerous. Most importantly, I want to give you the tools to have an informed, thoughtful conversation with your doctor about what your cholesterol numbers actually mean at your age. This is not about rejecting medicine or ignoring medical advice. It's about recognizing that one approach does not fit everyone, especially when it comes to seniors. By the end of this video, you'll understand why a total cholesterol level of 240 may, in some cases, be safer than 200 after age 65. You'll learn what the research actually shows and which questions you should ask before agreeing to cholesterol medication. Stay with me, because this information has the potential to meaningfully affect your health and longevity. For decades, we've all been taught the same message. High cholesterol is dangerous. Lower is always better. Keep total cholesterol under 200. Anything above that number is viewed as a warning sign for heart attack or stroke. This belief has been reinforced so consistently for nearly 40 years that challenging it can feel almost unthinkable. However, it's important to understand where this belief came from. The foundation of modern cholesterol guidelines was built on studies of middle-aged adults, primarily men, most of them under 65. One of the most influential studies followed people beginning in their 40s and 50s and showed a clear link between higher cholesterol and higher heart disease risk in that age group. The issue emerged when researchers continued tracking those same individuals into their 70s and 80s. As people aged, the relationship between cholesterol and heart disease weakened. In some cases, it disappeared entirely. In others, it even moved in the opposite direction. I saw this firsthand with a 72-year-old retired engineer who came to my office several years ago. His previous cardiologist had placed him on the highest dose of statins after seeing a total cholesterol level in the mid-200s. Over time, his quality of life deteriorated. He developed constant muscle pain, struggled with low energy, and felt mentally foggy. Activities he once enjoyed, including time with his grandchildren, became difficult. When I reviewed his full lipid panel, a very different picture emerged. His total cholesterol was elevated, but his HDL, the cholesterol associated with protection, was exceptionally high. His triglycerides were low. Taken together, his actual cardiovascular risk was very low, and the aggressive treatment he was receiving offered little benefit while causing significant harm. I need to tell you something that could completely change how you think about your cholesterol numbers. This is information that may help you avoid taking medications you don't actually need, or, even worse, medications that could be harming you over time. I'm Dr. Maria Lee, and after more than 23 years working as a cardiologist, I've seen the medical system continue to rely on cholesterol guidelines that were never truly meant for people over the age of 65. Much of what seniors are told about cholesterol is still based on research done in younger adults, and that creates a serious and often overlooked problem. When a doctor sees a total cholesterol level of 240, the response is usually immediate. A prescription is written. A statin is started. The focus becomes lowering that number below 200 as fast as possible. That's the standard protocol. That's what doctors are taught. What rarely gets discussed is that the relationship between cholesterol and heart disease changes after the age of 65. Numbers that may have been protective earlier in life do not always behave the same way later on. What works at 45 does not automatically work at 70. There are strong reasons this isn't openly discussed. Cholesterol-lowering drugs represent a multi-billion-dollar industry, and there is little motivation to challenge guidelines that support that system. In this video, I'm going to share research that many physicians either aren't familiar with or don't emphasize. I'll also talk about real patients whose quality of life declined after aggressive cholesterol lowering, even though their cholesterol patterns were not actually dangerous. Most importantly, I want to give you the knowledge you need to have a clear, informed conversation with your doctor about what your cholesterol numbers truly mean at your age. This is not about rejecting medicine or ignoring professional advice. It's about understanding that one approach does not fit everyone, especially when it comes to seniors. By the end of this video, you'll understand why a total cholesterol level of 240 may, in some cases, be safer than 200 after age 65. You'll learn what the research actually shows and what questions you should ask before agreeing to cholesterol medication. Stay with me, because what you're about to learn could meaningfully impact your health and longevity. For decades, we've all heard the same message repeated again and again. High cholesterol is dangerous. Lower is better. Keep total cholesterol under 200. Anything above that number is treated as a warning sign for heart attack or stroke. This belief has been reinforced for nearly 40 years, so questioning it can feel almost uncomfortable. To understand why this belief became so powerful, we need to look at its origins. Modern cholesterol guidelines were built on studies of middle-aged adults, mostly men, and mostly under the age of 65. One of the most influential studies followed people starting in their 40s and 50s and found a clear connection between higher cholesterol and higher heart disease risk in that age group. The problem appeared when researchers continued following those same individuals into their 70s and 80s. As people aged, the relationship between cholesterol and heart disease weakened. In some cases, it disappeared. In others, it even reversed. I saw this clearly in a 72-year-old retired engineer who came to see me several years ago. His previous cardiologist had placed him on the highest dose of statins after seeing a total cholesterol level in the mid-200s. Over time, his quality of life declined. He developed constant muscle pain, felt persistently tired, and struggled with mental fog. Activities he once enjoyed, including spending time with his grandchildren, became difficult. When I reviewed his complete lipid panel, a very different picture emerged. Yes, his total cholesterol was elevated, but his HDL, the protective cholesterol, was extremely high. His triglycerides were low. Taken together, his actual cardiovascular risk was minimal, and the aggressive treatment he was receiving offered little benefit while causing significant harm. I began to wonder whether her cognitive decline might be connected to her extremely low cholesterol levels and years of statin use. We made very careful adjustments to her medications and significantly reduced her statin dose. Within 6 months, her family noticed clear changes. She was more alert, more present, and more like the person they remembered. Her total cholesterol increased to 210, and her primary doctor was alarmed, convinced this was putting her in danger. But Dorothy improved. The damage couldn't be fully reversed, but she regained a level of quality of life that had been taken from her by overly aggressive treatment of a number that likely was never dangerous at her age. Now, I want to be very clear about something. I am not saying cholesterol is unimportant. I am not saying that everyone should stop taking their medications. What I am saying is that the relationship between cholesterol and health changes fundamentally after the age of 65, and our approach to treatment must change with it. Guidelines that make sense for a 50-year-old man with a strong family history of early heart disease do not automatically apply to an 80-year-old woman with no cardiac symptoms and high protective cholesterol. So let's talk about what truly matters when evaluating cardiovascular risk in people over 65. It is not just the total cholesterol number. It is the complete picture. The first and most important factor is the ratio of total cholesterol to HDL cholesterol. This ratio provides far more useful information than total cholesterol alone. A total cholesterol of 240 with an HDL of 80 gives a ratio of 3.0, which is excellent. A total cholesterol of 200 with an HDL of 40 results in a ratio of 5.0, which is concerning. HDL is your protective cholesterol. It functions like a cleanup system, removing excess cholesterol from artery walls and transporting it back to the liver for processing. The higher your HDL, the greater your protection, regardless of your total cholesterol level. I've seen patients with total cholesterol levels well above 250 and HDL in the 90s who have completely clean arteries on calcium scans. I've also seen patients with total cholesterol under 180 and HDL in the mid-30s who already have significant arterial disease. The second key factor is triglycerides. Elevated triglycerides, especially above 150, signal that the body is not handling fats and sugars efficiently. This pattern is closely linked to insulin resistance, chronic inflammation, and increased cardiovascular risk. Triglycerides are strongly influenced by diet. Eliminating sugar and refined carbohydrates often leads to dramatic reductions in triglyceride levels. The third factor is LDL particle size and number. Standard cholesterol panels do not measure this, but advanced lipid testing can. Two people can have the same LDL value and very different risk profiles, depending on whether they have many small, dense LDL particles or fewer large, buoyant ones. Small, dense particles are far more likely to penetrate artery walls, trigger inflammation, and contribute to plaque formation. Larger particles are much less problematic. The fourth factor, and this one is critical, is inflammation. The blood test used to assess this is called high-sensitivity C-reactive protein, or hsCRP. Inflammation is what actually damages blood vessels and allows cholesterol to become dangerous. You can have elevated cholesterol with low inflammation and relatively low risk, or moderate cholesterol with high inflammation and significant risk. In an ideal world, inflammation markers would be measured routinely, but they are often overlooked. The fifth factor is the coronary calcium score. This is a specialized CT scan that measures calcium buildup in the coronary arteries, which reflects atherosclerotic plaque burden. It is one of the strongest predictors of future heart attack risk. A calcium score of 0 indicates very low risk, regardless of cholesterol numbers. A high calcium score signals advanced disease and the need for aggressive management, even if cholesterol levels appear acceptable. Let me tell you about George, a 68-year-old man who came to see me feeling confused and frustrated. His total cholesterol was 215, just slightly above the commonly cited cutoff of 200. His doctor insisted that he start a statin right away. George was hesitant. He felt well, had no symptoms, and had read about potential side effects. He wasn't convinced the medication was necessary. I ordered a more complete evaluation. We ran an advanced lipid panel and obtained a coronary calcium score. His HDL was 75. His triglycerides were 85. His LDL particles were mostly large and buoyant, not the small, dense type associated with plaque formation. His hsCRP, a marker of inflammation, was low. And his calcium score was 0. Completely 0. There was no evidence of active disease. His cardiovascular risk was extremely low. Based on the full picture, I told George he did not need statins. His numbers were excellent when interpreted correctly. His primary doctor was not pleased. He called me, upset that I was challenging his recommendation. But I stood by the evidence. George is now 73 years old. He is still not taking statins, still active, still healthy. His most recent calcium score remains 0. We spared him a medication he didn't need and side effects he would have experienced for no real benefit. Now we need to talk about the issue that makes many people uncomfortable: statins. These are among the most commonly prescribed drugs in the world. Medications like Lipitor, Crestor, Zocor, and Pravachol are extremely effective at lowering cholesterol. There's no debate about that. The real question is whether everyone over 65 with cholesterol above 200 should automatically be taking them. Based on the full body of evidence, the answer is no. For people who have already had a heart attack or a stroke, statins clearly reduce the risk of another event. This is known as secondary prevention, and the data supporting it is strong. But for adults over 65 who have never had cardiovascular disease, the situation is very different. This is primary prevention, and this is where the controversy lies. A major analysis published in JAMA Internal Medicine looked at statin use for primary prevention in people over the age of 75. The conclusion was striking. There was no reduction in overall mortality. Cholesterol levels went down, but life expectancy did not increase. What did increase was the rate of side effects. Statins are not harmless medications. The most common side effect is muscle pain and weakness, known as myopathy. In more severe cases, this can progress to rhabdomyolysis, a dangerous breakdown of muscle tissue that can lead to kidney failure. Studies suggest that between 10 and 25% of people taking statins experience muscle-related symptoms. That is not rare. It is common. For older adults, muscle strength is essential. It determines mobility, balance, independence, and fall risk. Anything that weakens muscles can have serious consequences. Statins also increase the risk of developing diabetes. Multiple large studies have shown that statin use raises diabetes risk by roughly 10 to 12%. In older individuals, diabetes brings a cascade of problems, including vision loss, kidney disease, nerve damage, and higher infection risk. Lowering cholesterol at the cost of diabetes is often a poor trade. Cognitive effects are another concern. Many patients report memory issues, confusion, and mental fog while taking statins. While research results are mixed, these reports were common enough that the FDA added a warning about possible cognitive side effects to statin labels in 2012. For someone in their 70s or 80s, anything that affects mental clarity and daily functioning is a serious quality of life issue. Let me tell you about Patricia, a 71-year-old woman who was started on statins when her total cholesterol reached 225. Within just 3 months, she began experiencing intense muscle pain in her thighs and calves. Everyday activities like climbing stairs or standing up from a chair became extremely painful. She told her doctor what was happening, but she was told it was likely arthritis, just normal aging, and that she should stay on the medication. She continued taking the statin for 2 more years. During that time, her mobility declined dramatically. She went from walking every day to struggling just to move around her own home. When she finally came to see me, the pattern was immediately clear. We stopped the statin. Recovery was slow, but over the next 6 months, her strength gradually returned. The pain eased. She regained her ability to move freely and, with it, her independence. She was angry, and understandably so. 2 years of her life had been taken away by a medication prescribed to treat a lab number rather than an actual disease. Her cholesterol today is around 235. She feels excellent. And based on the research we've discussed, her overall mortality risk is likely lower now than it was when her cholesterol was aggressively suppressed. So, what should you do if you're over 65 and your doctor tells you your cholesterol is too high? First, don't panic. The difference between a total cholesterol of 200 and 240 is not the emergency it's often made out to be, especially if you're over 65 and have no history of heart disease. Second, insist on seeing the full picture. Ask for a complete lipid panel that includes total cholesterol, LDL, HDL, and triglycerides. Ask for your cholesterol ratios. Ask for an HSCRP test to assess inflammation. Ask whether a coronary calcium scan makes sense to determine whether you actually have plaque in your arteries. Third, take a close look at your personal risk factors. Have you ever had heart disease or a stroke? Does anyone in your immediate family have a history of early heart attacks? Do you have diabetes, high blood pressure, or do you smoke? These factors often matter far more than cholesterol alone. Someone with no risk factors and cholesterol of 240 may be at much lower risk than someone with multiple risk factors and cholesterol of 190. Fourth, if statins are being recommended, ask clear and specific questions. What benefit is expected for someone your age with your risk profile? What is the likelihood this medication will help you live longer or prevent a heart attack? What side effects should you watch for, and how common are they? Are there other options that should be tried first? You have every right to understand why a medication is being suggested and what you can realistically expect from it. Fifth, remember that lifestyle changes are powerful and carry no harmful side effects. Regular physical activity, especially strength training to preserve muscle mass, is one of the most effective ways to protect both heart health and independence as you age. A diet rich in vegetables, healthy fats such as olive oil and nuts, and omega-3 fatty acids from fish has consistently been shown to reduce cardiovascular risk, regardless of cholesterol levels. Reducing inflammation through diet is critical. This means eliminating or drastically cutting back on sugar, refined carbohydrates, processed foods, and excessive industrial seed oils. These foods drive inflammation, insulin resistance, and high triglycerides. They are far more damaging than dietary cholesterol ever was. We now know that for most people, cholesterol in food has very little effect on cholesterol in the blood. Eggs are not the problem. Sugary drinks and ultra-processed foods are. Sleep quality also matters more than most people realize. Poor sleep increases inflammation and disrupts metabolic health. Stress management is just as important. Chronic stress raises cortisol levels, which promotes inflammation and cardiovascular damage. Finding ways to genuinely relax through time outdoors, meditation, social connection, or activities you enjoy has real protective effects. Let me give you one final example. James, age 74, came to me with a total cholesterol of 250. His doctor wanted to start statins immediately. Instead, we agreed to focus on lifestyle changes first. James committed fully. He began walking every day, joined a strength training program, removed processed foods from his diet, added more vegetables and fish, improved his sleep, and actively worked on reducing stress. 6 months later, his total cholesterol was still around 245. It barely changed, but everything else did. His HDL rose from 45 to 62. His triglycerides dropped from 180 to 95. His inflammation markers fell significantly. His cardiovascular risk dropped sharply, even though the total cholesterol number hardly moved. More importantly, James felt better than he had in years. He lost 20 pounds. His energy soared. His blood pressure normalized. His blood sugar improved. And he gained confidence in his health rather than fear driven by a single member. Statins are not harmless medications. The most common side effect is muscle pain and weakness, known as myopathy. In more severe cases, this can progress to rhabdomyolysis, a dangerous breakdown of muscle tissue that can lead to kidney failure. Studies suggest that between 10 and 25% of people taking statins experience muscle-related symptoms. That is not rare. It is common. For older adults, muscle strength is essential. It determines mobility, balance, independence, and fall risk. Anything that weakens muscles can have serious consequences. He avoided statins completely and ended up healthier than he had been in decades. His experience highlights a crucial truth. Health is not defined by a single lab value. It's defined by how well your entire body is functioning together. Now I want to address another critical issue that is rarely talked about. As we age, the benefits of lowering cholesterol gradually decrease, while the risks of medication side effects increase. A 50-year-old has many decades ahead where preventing arterial disease may provide long-term benefit. An 85-year-old has a much shorter time horizon. In that setting, the potential benefit of aggressive cholesterol lowering is often small, while the immediate risks of medication can be substantial. At this stage of life, quality of life matters enormously. What is the value of gaining an extra year if that year is dominated by muscle pain, fatigue, mental fog, or loss of independence caused by medication? This is not just a medical question. It's a values question. Different people will answer it differently, and that is perfectly reasonable. But no one can make that choice wisely without being given the full information. The medical community is slowly beginning to acknowledge these realities. In 2019, updated guidelines from major cardiology organizations recognized that cholesterol treatment in adults over 75 should be individualized. They emphasized clinical judgment, patient preferences, existing medical conditions, and life expectancy when deciding whether statins are appropriate. This was an important step forward. Unfortunately, many clinicians have not adjusted their practice. They continue to rely on outdated algorithms that treat everyone the same, regardless of age. Statins are still prescribed reflexively to anyone with cholesterol above 200 without considering the broader context. At the same time, pharmaceutical companies continue to push for wider use of these drugs because it is profitable, not necessarily because it is best for patients. Let me tell you about Barbara, an 82-year-old woman who still gardens, volunteers regularly, and travels. Her cholesterol has hovered around 235 for more than 20 years. Every physician she has seen has tried to put her on statins. She has declined every time. She has outlived her husband and many of her peers. She has no heart disease, no diabetes, sharp mental clarity, and an excellent quality of life. At her last visit, she said something that stuck with me. She said, "I've decided I'm not treating numbers anymore. I'm living my life. If my cholesterol wants to be 235, that's fine with me." And she was right. She understands her body, her priorities, and her values better than any guideline ever could. That said, the opposite can also be true. Some people over 65 absolutely do need aggressive cholesterol management. If you've had a heart attack or a stroke, if you have advanced arterial disease, or if you have familial hypercholesterolemia, a genetic condition that causes extremely high cholesterol, treatment is essential. If your cholesterol is extremely elevated alongside very low HDL and very high triglycerides, that is a completely different situation. Context always matters. The message is not that cholesterol stops mattering after 65. The message is that it matters differently. We must stop applying guidelines designed for middle-aged populations to older adults where the evidence is inconsistent or weak. We need to ask better questions. Instead of asking whether cholesterol is above 200, we should be asking, what is the person's actual cardiovascular risk based on all available data? Is there evidence of arterial disease? What is the inflammation level? What does the HDL look like? What are the person's goals? What is their quality of life? What matters most to them? Let me share one final story that brings all of this together. Thomas, age 76, came to me after 3 different doctors over 5 years had tried to pressure him into taking statins. His total cholesterol was 228. He felt great and didn't want medication, but the constant pressure was starting to wear him down. He felt guilty, as if he were being irresponsible with his health. We did a full evaluation. His HDL was 72. His triglycerides were 88. His LDL particles were predominantly large. His inflammation markers were low. His calcium score was 15, indicating minimal disease for his age. His blood pressure was normal. He exercised regularly. He didn't smoke. His diet was solid. I told him the truth. Based on the best available evidence, especially for someone his age with his overall profile, his cardiovascular risk was low. Lowering his cholesterol further might change a lab number, but it was unlikely to help him live longer or feel better. In fact, it could easily make him feel worse. The relief on his face was unmistakable. He said, "Thank you for treating me like a person instead of a number." That sentence has stayed with me. It's what we should be doing for every patient, especially for seniors who deserve care based on their individual circumstances, not one-size-fits-all protocols designed for a different stage of life. Thomas is now 81 years old. His cholesterol is still around 230, and he is healthy, active, and thriving. He made a decision based on complete, accurate information, and it was the right decision for him. That is what medicine is supposed to be, an informed partnership between doctor and patient, not blind adherence to guidelines that may not even apply. Here is the key takeaway from everything we've discussed today. After the age of 65, the relationship between cholesterol and health changes in a fundamental way. A total cholesterol level of 240 is not automatically dangerous, and in some cases, it may even be safer than 200. Research in older populations shows that higher cholesterol is often associated with longer life and lower overall mortality. But context is everything. What truly matters are your HDL levels, your triglycerides, inflammation markers, particle size, calcium score, and your overall cardiovascular risk profile. Statins are powerful medications. They're helpful in certain situations and for certain people, but they are frequently overprescribed to older adults for primary prevention, where benefits are uncertain and side effects are both real and common. Muscle pain, increased diabetes risk, and cognitive changes can significantly reduce quality of life. You have the right to ask questions. You have the right to demand full information. And you have the right to make decisions based on your own priorities and values, not guidelines designed for much younger populations. Lifestyle interventions remain incredibly powerful. They have no negative side effects and should always be the foundation of healthy aging. Regular movement, real unprocessed food, stress reduction, quality sleep, and meaningful social connection do more for long-term health than any cholesterol drug ever could. These habits address root causes rather than simply manipulating lab numbers. Before we wrap up, I want you to do something important. If this information was helpful, if it challenged what you thought you knew, or if it gave you better questions to ask your doctor, please share this video. Think about your parents, your friends, or anyone over 65 who has been told their cholesterol is too high and that medication is the only answer. This video could start a conversation that genuinely changes their health trajectory. And subscribe to this channel. My goal is to cut through medical dogma and bring you evidence-based information that treats you as an intelligent adult capable of making informed decisions. Too often, medicine has become paternalistic, telling people what to do without explaining why. You deserve better. Here is your action plan. First, if you're over 65 and concerned about cholesterol, get the full picture. That means a complete lipid panel, inflammation testing such as hsCRP, and consideration of a coronary calcium scan. Do not make decisions based on total cholesterol alone. Second, have an open and honest conversation with your doctor. Bring questions. Ask about your actual risk, not just a number. Ask about alternatives to medication. Ask about realistic benefits and potential harms. If your concerns are dismissed or discussion is discouraged, it may be appropriate to seek a second opinion. Third, invest seriously in lifestyle. You cannot out-medicate poor habits, but you can often reduce or eliminate the need for medication by improving how you live. Fourth, make decisions based on your values. What matters more to you, more years or better years? There is no universal right answer. Your priorities are valid. And fifth, stay informed. Medicine is constantly evolving. Guidelines change. New evidence emerges. What was considered unquestionable truth 5 years ago may look very different today. Cholesterol management after 65 is a perfect example of how medical beliefs can lag behind the data. We are still treating cholesterol as the primary enemy in older adults, even though the evidence no longer supports that narrative. Change in medicine is slow, especially when billions of dollars are involved. But you now have information that many people, including many physicians, have not fully considered. Use it wisely. Use it to advocate for yourself. Use it to ask better questions. Use it to make decisions that align with your health goals and your life priorities. Your health is too important to leave entirely in someone else's hands, even when those hands belong to a well-intentioned doctor following outdated guidance. I hope today's discussion empowers you. I hope it gives you confidence to question, to seek clarity, and to demand evidence. Your heart has been working for decades. It deserves thoughtful, individualized care, not automatic reactions to a single number on a lab report. Take care of yourself. Respect your body's wisdom. And remember, numbers are just data. You are a whole person with a unique history, unique genetics, and unique needs. Thank you for watching. I'll see you in the next video, where we'll continue exploring medical myths and long-standing guidelines that deserve serious reconsideration. Stay healthy, stay informed, and stay empowered.